Endovascular coiling, previously coiled basilar apex aneurysm. Using neck remodeling device. This was in February 2012. The surgeon and narrator are Dr. Michael Horowitz. Here we see a previously coiled aneurysm. This was a ruptured aneurysm that had been treated 6 months earlier. At that time, a neck remodeling device was not used because this was a ruptured lesion. We can see residual filling within the coils. The residual filling will need to be treated at this stage. Here we have a road-mapped image. We are advancing a microcatheter and wire, and we'll place it within the residual aneurysm. Several manipulations will be needed in order to place the catheter between the coils that were placed in the aneurysm 6 months earlier. We are trying to get the catheter into the pocket that is still filling with blood in contrast. The wire is being directed towards the portion of the aneurysm that is still filling. Once we are in that area, the catheter will be advanced into the area that we want to treat. The catheter has been advanced into the section of the aneurysm that we will be treating. The wire is removed. The catheter cannot be seen on this run. A second catheter and wire are being placed. This one is going through the basilar artery into the right posterior cerebral artery. This larger catheter will be placed in order to add a neck remodeling device across the neck of the aneurysm. Here the wire is placed from the basilar artery into the right posterior cerebral artery, and a second microcatheter is being advanced into the right posterior cerebral artery. The first microcatheter is already in the aneurysm, although it is difficult to visualize on this run. The delivery wire is removed from the second catheter. We will now advance a stent or neck remodeling device. It is advanced up the second catheter and across the neck of the aneurysm. Here a coil is being placed into the aneurysm first. The neck remodeling device is being placed so that as more coils are added to the aneurysm, the coils do not herniate out of the aneurysm into the parent vessels, thus causing a stroke. Our goal is to only keep the coils within the aneurysm and not allow the coils to enter the vessels that are supplying the brain. Here the coil is being manipulated with the catheter in order to get it to sit within the aneurysm. The microcatheter has been retracted slightly. We can see the tip, and it is now advanced back into the aneurysm. The coil will be advanced into the portion of the aneurysm that is continuing to fill. Here we see it wants to fall out of the aneurysm. We withdraw it and advance it again until it stays within the aneurysm. This often requires several different manipulations until we are satisfied that the coil is in a good position. Here the neck remodeling device or stent is being advanced through the second catheter. As we deploy the stent by pulling the catheter out and releasing the stent into the vessel, we will intentionally leave the more proximal end of the stent out of the basilar artery and in the apex, so that the stent actually runs from the right posterior cerebral artery into the left posterior cerebral artery. We will essentially place a stent across the horizontal segment of the top of a T. This stent or neck remodeling device will cover the entrance to the aneurysm, thus stopping any additional coils that are placed into the aneurysm from entering the parent vessel. The stent, which is quite difficult to see on this run, is sitting across the neck of the aneurysm. An additional coil is now placed into the aneurysm through the first microcatheter that sits within the aneurysm. Another coil is being placed into the aneurysm. These coils now sit nicely within the residual portion of the aneurysm and do not fall down out of the aneurysm into the parent vessel because the stent is across the bottom of the aneurysm holding them in. This subtracted image that we see here will make it easy to see the new coils entering the aneurysm. Here a coil is being advanced into the already existing coil mass. The darker area within the coil mass represents the new coil that is being placed. Once again, several manipulations are needed in order to get the coil into the proper position within the aneurysm. We once again reposition the coil until we have it completely within the aneurysm. It's now in good position and will be released. The darker area in that image represents a new coil that's been placed. Another coil is now being placed within the aneurysm. This one went in quite easily, indicating that there is more room to be filled and more work to be done. Another coil is now being placed within the aneurysm. We see that it is filling a portion of residual aneurysm on the left side of the screen. We are advancing this coil slowly so as not to rupture the aneurysm. The coil is released. An arteriographic run is done, showing that the aneurysm no longer fills. The residual portion seen earlier in the study has now been filled with coils. The dark mass represents the aneurysm. A repeat run shows no filling of the aneurysm. All other vessels fill normally. Here was the residual filling that the arrow is pointing to. This traces the area that was filling prior to retreatment. This shows this one end of the stent in the right posterior cerebral artery and the other end of the stent or neck remodeling device in the left posterior cerebral artery. Here's the aneurysm at the edge of treatment. The stent extends across through the vessels, across the base of the aneurysm, and there's no residual filling of the aneurysm. The arrow points to the area that had been filling with contrast and blood previously. Here the two arrows point to the two ends of the stent. Final run shows complete treatment with all other vessels filling normally. One does note that at the base of this aneurysm, some coil is extending into the right posterior cerebral artery. This coil was present from the previous procedure. It most likely sits against one of the walls of the vessel between the currently placed neck remodeling device or stent and the vessel. It is not hanging into the lumen of the vessel and should not pose any risk to the patient. This patient will be managed with aspirin and Plavix for 6 months and will remain on aspirin afterwards.